Our next topic is gestational diabetes and the crystal ball, and presenting is Julie Daley, Director of the Diabetes and Pregnancy Program at Women and Infants Hospital. Julie is also a clinical teaching associate in obstetrics and gynecology for the Warren Alpert School of Medicine at Brown University. She is nationally and state certified in diabetes education, and she's here today to provide some insight into gestational diabetes. So welcome, Julie. We're honored to have you here with us today to celebrate Rhode Island World Diabetes Day. You're on mute.
There we go.
There you go.
Okay.
Great.
So thank you, Randy, for that nice introduction. I'm very happy to be here with you today. And as you explained, I am going to be talking about gestational diabetes and the crystal ball. So basically, my position at Women and Infants involves taking care of women with type 1, type 2, or gestational diabetes. So what I'm going to be talking about today is what is gestational diabetes, how we treat it, what we do after the baby is born, and lastly, we're going to discuss the crystal ball. So gestational diabetes is diabetes that's usually diagnosed in the second or third trimester of pregnancy. So a pregnancy is divided into 3 trimesters. Each of them are 3 months long. And gestational diabetes affects about 2 to 10% of all pregnancies. So as I'm sure has been mentioned today, what happens is when we eat, we change food to glucose that goes into our bloodstream, and it needs to get into the cells of our body in order to be used for energy. So insulin is kind of the bridge that gets it in there. What happens when a woman gets pregnant is her body starts to make about 6 hormones that it only makes while a woman's pregnant. Every week of a pregnancy, they make more of those pregnancy hormones. And those hormone levels can get high enough to start to make a pregnant woman resistant to insulin. So pregnant women usually make 2 to 3 times as much insulin during a pregnancy as they do outside of pregnancy. And so somewhere between 2 and 10% of pregnant women can't do that, and they end up having gestational diabetes. So why do we worry about gestational diabetes? It's only happening while you're pregnant. For the most part, it goes away after pregnancy, but there are lots of risks involved to both the mom who's pregnant and the baby. So basically, I'm taking care of 2 patients at a time instead of just 1. So the risks to mom include having a higher risk of high blood pressure during pregnancy, preeclampsia, which is commonly known as toxemia, which is really something that we don't understand very well, can't control very well, and usually is an indication for delivery. The other risk to mom is a higher rate of cesarean section. And for those of you out there who have diabetes, if you can think back to about to when you first got diagnosed and all the things that went through your head, all the concerns you had, all the fears you had, all the worries you had. Women with gestational diabetes get all of that all at once, and they worry about how this is going to affect their baby. So as all of you who have been through this know, it's emotional. There's a very strong psychological component. Anybody who has diabetes or knows anybody with diabetes knows how much diabetes can cost. And the other thing that we worry about for pregnant women with gestational diabetes is that somewhere between 50 and 70% of them will develop type 2 diabetes someday. If we followed pregnant women from the moment they deliver until they're 100 years old, anywhere between 50 and 70% of them will get type 2. And then what about the baby? You know, pregnant women are all, for the most part, are very excited about their pregnancies and looking forward to the perfect pregnancy, a perfect baby. But there are risks to the baby also when a mom has gestational diabetes or even diabetes of any type. They have a risk of having a very big baby, and that's because if the mom's blood sugar is high, it crosses to the baby, and the baby's going to take that glucose if it's more than they need to grow, and they're going to store it as fat, just like the rest of us do when we eat too much. And we don't know why, but babies tend to put that extra weight on in their shoulders and their chest and their bellies. So when a woman goes to deliver, usually the head comes out first. And if you've ever noticed, newborn babies, for the most part, have heads that look like they're too big for their bodies. And then the body comes out with another couple pushes after the head is finally delivered. And so the fancy term for that is called shoulder dystocia, which basically means it's difficult, more difficult than usual to get the baby's body delivered. Now, the other thing that can happen that's related to mom's blood sugar is if mom's blood sugar is high and the baby is used to getting that elevated level of blood sugar day in and day out all day long, a baby is very rarely born with diabetes. Babies can make insulin very early in their pregnancy. So they will make insulin, but the baby's insulin can't cross back to the mom. If it could, babies would cure diabetes and moms would want to be pregnant all the time. Julie wouldn't have a job. So what happens is that extra blood glucose goes over to the baby. The baby's going to make extra insulin. The baby's going to store it as fat. But then when the woman delivers, we cut the cord. So you are immediately stopping that flow of glucose to the baby. And the baby needs time to get used to making less insulin. Just like when newborn babies are born, we usually put them in a warmer because they need time to get used to the temperature. If they've been used to making a lot of insulin, they need time to slow down. And while they're slowing down, that insulin's actually going to force that glucose from the baby's bloodstream into the cells of their body, and they can have a low blood sugar, just like any of us do. So we can treat it. We feed them just like any of us would. First line of action would be to have a snack. If our blood sugar is low, we feed babies. The other thing that can happen to babies is they have a higher risk of having difficulty breathing when they're born. And it's kind of a complicated thing. Generally speaking, babies' lungs don't mature as quickly if a mom has diabetes of any kind. And the worse their blood glucose control is, the more likely this is to happen. And so what can happen is their lungs don't mature as quickly. The baby gets delivered. The baby may have to be delivered prematurely, and they have more breathing difficulties than full-term babies of non-diabetic women do. So how do we diagnose gestational diabetes? Well, the answer is we don't do it by looking into the crystal ball. That doesn't tell us much about who's going to have it and who doesn't. We have a long laundry list of people who are at higher risk of getting gestational diabetes, but going just by risk factors would miss half the women who have it. So what we do is we test every pregnant woman for gestational diabetes. So what we do at Women and Infants, we do what's called a two-step process. They get a 50-gram glass of glucose, and we draw a blood sugar an hour later. We do it at a regular prenatal visit. They don't have to be fasting or anything. If that comes up above a certain cutoff, we then will have the woman do a 3-hour glucose tolerance test, which will actually diagnose the diabetes. So what happens is The woman can't eat after midnight. She goes to the lab fasting the next day. She gets 100 grams of liquid glucose, and then she has to hang around the lab for 3 hours and get a blood glucose level drawn at 1 hour, 2 hours, and 3 hours after the drink. So we have 4 values. If any 2 or 3 or 4 of those numbers are elevated, we diagnose a woman with gestational diabetes. The American College of Obstetricians and Gynecologists also say that if a practitioner feels it's worthwhile, they can diagnose a woman with gestational diabetes if only one of those values is elevated. So then, now we've got a woman who's upset, wants to know what to do to protect their babies, how we treat this. And basically, there are 3 different ways that we treat this. So just like anyone who gets diagnosed with diabetes, the first plan is to meet with a registered licensed dietitian nutritionist to get a meal plan. The second thing we do is have women test their blood sugars to find out if this meal plan is working. And if necessary, we use medicine that's safe to use during pregnancy. So I'm going to go through each of those. So basically the nutrition recommendations, just like someone who has diabetes, is to eat healthy. So I'm sure there's been lots of talk today. Food is made up of carbohydrates, protein, and fats. So we want a woman to have a healthy, balanced diet. We do not want her eating a protein-only diet. So carbohydrates are the kind of food that are going to affect blood glucose levels the most. So we focus most of our attention on those. And there are several pictures there of carbohydrates, some of which are healthier than others. So sugar is only one kind of carbohydrate. Fruits, milks, grains, starchy vegetable, legumes are all carbohydrates. They will turn into blood sugar and enter our bloodstream. And depending on the type of carb, what it's mixed with, it basically gets digested, starts in about 15 minutes or so. The peak is usually between 1 and 2 hours after. So carbs are not bad. Probably most of you realize that. Carbs are healthy. Babies' brains need carbs to function. Babies' brains need carbs to function. All of the cells of our body really need some glucose to function. So we don't eliminate them. But we know that large amounts will raise your blood sugar. The more you eat at one time, the higher your blood sugars may go, and the more insulin a pregnant woman's body will have to make at one time. So what we try to do is spread out that load during the day. So we limit simple sugars that do not have much nutritional value, like the donuts and the cookies and the cakes. And then we choose healthy carbohydrates. So healthy carbs are ones that contain things like minerals, vitamins, fiber, less processed food. Foods that have a lot of fiber will get digested more slowly than foods that are more processed. And lots of healthy carbs also have some protein that are good for babies to grow, good for mom's health. So we always try to include protein with every meal and every snack. So here are some types of animal proteins. Milk and yogurt have carbs but contain protein also, vegetable proteins, and then we have some foods that contain carbs and protein, like beans, peas, lentils, and soy. And most proteins, or at least the ones with the beans, are also high in fiber. So we concentrate on adding more fiber to their diet, more protein to their diet. And basically what we do is we spread their food out into 3 smaller meals, And then we give them 3 snacks in between, so they're not getting a large carbohydrate load at one time. Having them keep their portions, it's easier to keep portions smaller if you're eating every 2 to 3 hours. Excuse me, we include meals and snacks that include protein. So we include protein in every meal and snack. We encourage women to drink 0-calorie beverages. We want them to stay hydrated. They need to drink fluids, but we try to stay away from things like regular soda and include 0-calorie beverages. And then we ask the woman, to keep a food diary to look for trends. So they will meet with a nutritionist at least a couple times at first and then more often as needed. We look at the food, we look at their blood sugars, and then we try to see if we can move things around and fix it with just the meal plan. So we teach women to set up a plate similar to kind of these. These are examples where half the plate is vegetables. Vegetables are very low in carb and very healthy, other than starchy vegetable like peas or corn. So we encourage women to eat plenty of fresh vegetables. So we ask them to make a quarter of their plate a protein type food and only a quarter of their plate a healthy carb. So we usually teach women, we don't get into very much carb counting unless it's someone with type 1 or type 2 who's done it before. But for a woman who's new to gestational diabetes, we basically use things that they can use to compare at home. Like a serving of rice is the size of a tennis ball, the size of a woman's fist, a cup cooked. And then we ask them to have a healthy portion of protein. And if they're still hungry, to go back and eat more of the carb and more of the protein. Excuse me, I'm just getting the sun out of my eyes. All right, maybe that's better. Okay, so that's what we ask them to make their plate look like. And then we ask them to test their blood sugars. So we ask them to test at least 4 times a day. For women with gestational diabetes, 4 times a day is usually more than enough. So we ask them to test a fasting blood sugar. And during pregnancy, a goal for a fasting blood sugar is below 95. There are some institutions that even like below 90. Even for women with type 1 and type 2 diabetes, we use these same glucose targets because the blood with this glucose in it is crossing to the baby. So 2 hours after meals, we would like their blood sugars to be less than 120. If someone is testing at 1 hour after a meal, for several reasons, they have a history of a gastric bypass, they can't wait that long, they're hungry, we ask them to eat at 1 hour, which we don't. We prefer for a woman never to be hungry. Or at night, if a woman has trouble staying awake and they're not staying awake for 2 hours, then getting a blood sugar at 1 hour and using a cutoff of 120 is better than getting no blood sugar at all. The second thing we encourage women to do, if there's no reason medically or obstetrically why they can't, is to get some exercise. Just the same as all the rest of us, exercise is healthy. Exercise is going to burn some calories. It's going to make your insulin work a little more efficiently. It's healthy. It's going to help women when it gets time to be in labor. But we also encourage women to stick to exercises that their body can tolerate. So in the summertime, pools are great because the water is supporting that extra weight of their belly. Walking, an exercise that a woman's used to doing. We don't expect anybody to take up running marathons while they're pregnant, just a little exercise. And then we have to decide when medications should be started, when should we do this, and then what medications are safe to use during pregnancy. So When would we start it? Would be if the majority of blood sugars at any given point of the day are not in good control. So let's say just the fasting's elevated, we might give them a little insulin at night just to control that one. If their blood sugars are up all day, then we'll come up with a regimen that will cover all day. Insulin is the preferred medication. It is safe to use during pregnancy. It does not cross the placenta to the baby. So it is our preferred medication. Yes, a woman could even put insulin in her belly. That little needle is not going to get near her belly. But most pregnant women prefer to do the tops of their legs or the back of their arms. Most women who had diabetes before they were pregnant have no problem using their bellies. Women who have gestational diabetes tend to have a little more problem with that. A common question I get is, why can't I take a pill? So there have been research studies using a couple of different medications for type 2 diabetes in women with gestational diabetes. Basically, they have been shown to cross the placenta to some extent, and we prefer to give a medication to a pregnant woman that does not cross to the baby. So we usually prefer insulin. And then we still have to take care of the pregnancy. So they come for routine visits. They get their blood pressure checked. They get ultrasounds. They consult with the physician regularly, with one of the diabetes educators. We ask women to report their blood sugars to us twice a week, because every week of their pregnancy, a pregnant woman's making more of those hormones that make her more resistant to insulin and make her blood sugars go up. So it's a very labor-intensive time in a woman's life. And then once the woman has her baby, the placenta comes out afterward. So in my little picture here, this is a baby in utero. This would be the placenta. This is what made the hormones that caused the problem. So once the woman delivers this beautiful baby, that placenta comes out afterwards, and it causes a rapid, within hours, loss of placental hormones. And so as those hormones go down, the woman's blood sugars go down right after. And we generally say, no more gestational diabetes. And I do the happy dance, because most women are thrilled to have that news. However, we'll get back to the however. So breastfeeding is recommended for all women, including those with gestational diabetes. Even women with type 1 or type 2 diabetes can breastfeed. Many more medications for diabetes are safe to use during breastfeeding than are safe to use during pregnancy. So we do recommend every woman breastfeed. There are just a myriad, I'm going to say that word wrong, but there are lots of reasons for breastfeeding, and I'm going to get to a couple of them shortly. So after the woman delivers, we do recommend that she has a glucose tolerance test that's done outside of pregnancy to diagnose diabetes. It's a 2-hour glucose tolerance test. It's 70 grams of glucose. So the woman gets a blood sugar drawn, a fasting blood sugar, takes a 75 gram of glucose drink, and gets a 2-hour blood sugar drawn. This is generally done between 4 to 12 weeks postpartum. And we do this just to make sure that the diabetes has gone away after the placenta has delivered, and that a woman was not aware that she had diabetes. And we do find it, that women get that postpartum glucose tolerance test and they have type 2 diabetes or even pre-diabetes. And we do recommend that a woman get screening done every year, whether that's just a fasting glucose, a random glucose, a hemoglobin A1C, in order to be sure they don't have type 2 diabetes. The reason is, as we all are probably aware, the earlier one can diagnose it, the less damage that diabetes has done to your body and the easier it is to treat. So we do recommend that women follow up the rest of their lives. Now, women who have had diabetes in one pregnancy have about a 67% chance, about 2/3 of them will get gestational diabetes the next pregnancy. Not a reason not to have more babies. We just do recommend that they get a test done. If the pregnancy is planned, we recommend that they get a test done in order to make sure they don't have type 2 diabetes before they get pregnant again. The reason we do that is because we would want to make sure their diabetes is in good control before they get pregnant. So now comes the crystal ball. All right, everybody's wondering, when the heck is she going to get to the crystal ball? So the crystal ball tells me that 50 to 70% of women with gestational diabetes will develop type 2. So it's a red flag. There are not many conditions where a person will get a warning that they're at an elevated risk of getting this. So what this does is hopefully motivates women who have had gestational diabetes to do all the things they need to do to cut down their risk of getting diabetes someday. Hopefully, seeing in this crystal ball this risk will make women more likely to do the things they need to do, like continue to eat healthy, like exercise regularly, attempt to take off any weight, all the things that we recommend in the diabetes prevention program. So these are all the ways that women can help prevent type 2 diabetes. Eat healthy, looking in a crystal ball and seeing healthier meals will help cut down their risk. Any amount of weight loss, and we know it only takes a small amount of weight loss to cut down somebody's risk of getting diabetes. Exercising regularly. I tell women, even if you're not losing weight, keep exercising regularly. And the fourth way is breastfeeding. That pink breastfeed doesn't show up too well in that crystal ball, but it's in there. Studies have shown that women who breastfeed cut down their risk of getting diabetes someday. And the longer they breastfeed, the more they cut down their risk of getting diabetes. And for women, it adds up over pregnancies. So the more time a woman spends breastfeeding in her life, whether that's over 2, 3, 4 children, the more she's going to cut down her risk of getting diabetes someday. It also cuts down her baby's risk of getting diabetes someday. And the longer she breastfeeds her baby, the more she cuts down her baby's risk of getting diabetes someday. So that's just 2 more of the diabetes related good qualities and advantages for women breastfeeding. So that's one of the reasons, 2 of the reasons why we recommend breastfeeding even to women who have gestational diabetes. So there is a study going on that I'd like to bring to anyone's attention. It's called the Gestational Diabetes Prevention Program. It's for women who have had gestational diabetes in one pregnancy and would like to try to prevent it in a second pregnancy. And it's kind of based on the DPP, the Diabetes Prevention Study, to see if healthy eating and exercising regularly will cut down a woman's risk of getting it the next pregnancy. So I'm going to go off subject for 1 minute, the last thing I want to talk about. And I know I alluded to it sooner, and I apologize in advance. I do not intend to offend anybody's religious beliefs, but this is scientific evidence. So we know that if women with type 1 and type 2 diabetes can get their blood sugars down to a healthy, normal level of an A1C at least below 7, if not below 6.5, we can cut down their risk of having a baby with birth defects and a miscarriage. So women who have type 1 and type 2 get pregnant, if their A1C is above 6.5 to 7%, they have twice the risk of having a baby with a birth defect as a woman who does not have diabetes. they have a higher risk of miscarriage. And if we get those blood sugars down to pregnancy values before a woman gets pregnant, we cut down their risk to the same as everyone else's. So when should we start talking about this? We should start talking to women about who have type 1 or type 2 before or as soon as they hit puberty, so that we can see great things in the future for women who have type 1 and type 2, who can cut down their risk of the things that can go wrong by being pregnant and having type 1 or 2. And so that's the end of the story about the crystal ball. So please tell any woman you know who's got type 1. Tell anyone you know who dates a woman with type 1. Tell your cousins, tell your sisters, call your aunts. Any woman with type 1 or type 2 diabetes is going to give her baby a much healthier start by controlling those blood sugars before she gets pregnant. So I want to thank you all for your attention. I want to, let's see if we can go back. Thank the committee for inviting me to speak. I want to wish everyone a happy World Diabetes Day, and hopefully we're all going to live to see the cure for diabetes. Thank you.
Thank you so much, Julie. Really interesting information that you've shared. And we actually do have a question that came in through the chat. Can continuous glucose monitoring be used during gestational, and will insurance cover it?
Let me talk about all kinds, because unfortunately, the FDA has not yet approved continuous glucose monitoring for use in pregnancy in anyone, in any women type 1, type 2, or gestational. We use it though. It's considered off-label and it's wonderful. I don't know, at least in this state, of any insurers that will cover continuous glucose monitoring for women with gestational diabetes. Women with gestational diabetes tend not to have the fluctuations in glucose levels that women with type 1 or type 2 even diabetes have. There is one out there that retail price is no more expensive than the retail price of buying glucometer and test strips. I don't want to be promoting any particular brand of anything, but for the most part, the answer to that is no.
Thank you. Any other questions from the audience?
Now, can I add one thing to that?
Of course.
If a woman who is absolutely petrified to test her blood sugars, we would attempt to put in a prior authorization with her insurance company to try to get it covered during pregnancy, because it would be better than having no blood sugars at all. And the lack of information in the world of obstetrics is as bad as bad information. Mm-hmm. So we have a little saying that goes, no blood sugars are as bad blood sugars.
Great. Thank you for clarifying. And there is another question that's come in. Can you address contraception for women with type 1 or type 2 who do not want to become pregnant? Is one method better than another?
No, I believe any method of contraception is okay for a woman with type 1 or type 2. It is more important that a woman who doesn't want to get pregnant or whose blood sugars should use contraception, because unwanted pregnancies can be dangerous if a woman's blood sugars are not in good control. There used to be a couple of them that claim to make blood sugars go up, but if it's, the alternative is worse than not using contraception.
Thank you for clarifying, Julie. Any last minute questions? So Rhode Island, let's thank Julie again for an informative presentation.